the other things that we've talked about this morning as far as how to put this together, how to find those early lesions, how to get them off, and how to feel comfortable with this approach. I think we've all seen a number of pictures where it's very scary. You know, is that really melanoma or is it not melanoma? So I hope I can kind of bring that all together as part of the approach of this lecture. I did want to point out that a number of the slides are from Ashmark Group that are also included in this talk. So really one of the first questions that we should ask if we're trying to undergo this effort of finding melanomas early is, does it make a difference? And luckily there has been data from Germany where one particular county was screened while the rest of the counties around it were not. And really, just in brief, from that screening, roughly they saw just under a 50% reduction in mortality, both in men and women. So there's really very little doubt that by identifying melanomas early and removing them, we can save lives. So this is something that I think many of us felt was the right thing to do, but at least now we're getting more and more data to suggest it does make sense to pay attention to these patients and to try to catch these tumors early. It can be a little daunting. It can be a little bit scary on how to follow these folks. We'll kind of go a little bit through that. So the first part is, who's at risk? Basically, patients that grow lots of moles have the risk of making a malignant mole. So patients with very high mole densities are at high risk. And mole density really kind of tells us two things. It tells us, one, they've inherited the genetic risk factors that allow them to do this. But it also is a readout on their environmental exposures. Certainly there's a tight association with UV exposure. So you get both the, does this person have the inherited risks, and does this person have the environmental exposure, which may place them at increased risk for developing melanoma. Now, a lot of statistics, a lot of reports have been put together, and it's quite clear that the more moles you have, the greater your risk for melanoma. And basically, you can actually calculate this out, count the number of moles in the patient. You can tell them what their relative risk is compared to somebody with very few moles. If you don't want to do the whole body, you can actually just do the arms and also get very good statistics on what is their relative risk. More moles, more risk. The other thing that's interesting is the more atypical the moles are, the more risk you have. So the more, and also the number of them that you have also correlates with risk. So the more atypical moles, the greater your risk for melanoma. And there are very good numbers for this. How many atypical of dysplastic nevi do you have? This is your relative risk compared to somebody that doesn't have any of these moles. But it's not just having the atypical moles. It really is how atypical they are, potentially how large they are. There's data that says the more challenging the pattern, the higher your risk. And if we step back to this idea of these things kind of being molecularly determined, somebody that has really these more unusual moles clearly have a higher risk of having pathways that aren't functioning very well, which might set them at higher risk for developing a melanoma. The other thing, of course, that weave into this is maybe they also make things that look like melanoma that aren't, so that these folks may also be at more risk of having biopsies and things removed that are called melanoma that may not be. So that also needs to be woven into the equation. Certainly, children or individuals with very large congenital nevi are at also increased risk of melanoma. There's really a large distribution on what that risk really is, but it's probably on the order of less than 1% if you group these individuals as a whole. Nevertheless, melanomas do happen, and do have to be watched very carefully. Sunburn, don't do this. Not a good thing for many reasons. There's very good data now that sunburns are associated with melanoma risk, particularly those folks that stay inside for most of the winter up north and then fly down to Florida to get cooked, have higher risk than folks that have more likely to have chronic sun exposure. When you get your sunburn is also important. The earlier in life, the greater your melanoma risk. Now, why is this? How does this happen? You know, I kind of like the stem cell idea I was talking about earlier, that you have cells, they're sitting there in the dermis or wherever they may be located. They acquire mutations earlier in life, maybe more of those cells early in life, maybe the skin is thinner earlier in life. But you put those mutations in, and then later in life you see the resultant melanomas. So clearly there's an increased risk for those sunburns early in childhood. So it's important to protect yourself throughout, but to protect the kids especially. Intermittent sun exposure has also been shown to have a risk. Chronic sun exposure, really the studies have not been shown a good correlation here, but I think we all know lentigo malignans are clearly tightly associated with the more chronic sun exposure. So there are opportunities there, I think, for better statistical studies. Tanning beds, you know, really a mistake. This is kind of our equivalent to smoking these days. You know, there is a very strong risk as well. Even, you know, a single first exposure before age 35 increases risk by about 75%. So just not a good idea. Skin phenotype plays a role, and you know, certainly as we get to fair skin types, there's increased risk. But what's interesting is there seems to be even further increased risk with pheomelanin. That red melanin is doing something special that causes increased risk for melanoma. We've got good statistics on these as regards your skin type, the amount of freckles, skin color, eye color, hair color, prior active keratosis or other skin cancers really are all associated with increased risk of melanoma. Family history, certainly if a patient has family history, you have increased risk. One parent can increase your risk twofold. One sibling can increase your risk threefold. If you have a parent and a sibling, your risk can be about ninefold. So, you know, pretty simple things for us to look at the patient. Really just by looking at them, you get a good idea of what their risk is. Asking questions about prior skin cancers and family history definitely can give us a handle on overall risk. Now, the incidence of familial melanoma is actually relatively low, roughly about 5%, which means that really this is the group that has those real high penetrance genes. But most of the rest of us probably have high prevalence but low penetrance genes that are giving rise to melanoma. A number of these really are the genes that can assign us to different skin color phenotypes: MCR, ASIP, tyrosinase, and TRP1, all having associations with increased melanoma risk. Now, when you look at that group of patients that have familial melanoma, that 5%, about a third of them are due to defects at this locus, the CDKN2A locus, which takes out both P16 interfacing with the retinoblastoma pathway and P15 interfacing kind of with the P53 pathway. Definitely taking the brakes off of a lot of those lesions in the skin, making it a lot easier for melanoma to develop. A second major player is CDK4, not listed on here is the MITF locus, which has also been identified. But still, for familial melanoma, we have a number of familial genes that still have yet to be identified. Certainly other disease states, particularly xeroderma pigmentosa, clearly at very, very high risk. These folks need to be protected and watched very carefully for certainly melanoma, but also their abundant non-melanoma skin cancers. So what's the approach? You got the patients, particularly who's at high risk. Really, how do you put all this together? I'm going to go over a little bit of what we went over earlier, but one of the things to note is that you really can't just remove these moles. Just removing moles is not going to reduce their risk. And the reason for that is that 3 out of the 4 melanomas are going to home in normal skin. So unfortunately, you really are stuck with watching them. And preventative molectomy doesn't work. You got to just kind of keep an eye on these folks. And you know, part of that is you can't predict which mole melanoma's going to develop. And I showed you this earlier. You know, you think it's that one, but it's a different one. So even for those 1 out of 4 melanomas that do come up in a mole, you're not going to know which one it is. And it's likely not to be the most dysplastic mole on the patient. You just don't know. So you've got to watch these folks. So kind of how do you put this together? Well, one of the things is that unlike benign nevi, melanomas tend to have a rare combination mutation. The brakes are off and the accelerator is hit. So they tend to actually basically appear a little bit more unusual, and they become more unusual as they grow. The second thing is melanomas do continue to grow. Benign nevi, basically, the brakes are put on and they stall out. So continued growth is certainly something to pay attention to. And as we talked a lot about, melanomas are genomically unstable. As they continue to grow, they become more and more non-uniform, essentially develop those characteristics that we see earlier dermoscopically or confocally, but do appear clinically and eventually result in those ABCDs. But I hope, as you realize today, you don't need to wait until the ABCDs develop to remove these melanomas. Melanomas are unusual, they're growing, and they're progressively becoming non-uniform. So in the clinic, how does this work? So a patient can come in and they can have a relatively standard nevus pattern. This is what their moles look like. What are you looking for? You're looking for a mole that just doesn't quite match their pattern. A patient with hundreds of these, just a dysplastic nevus. But in a patient like this, it really doesn't match your others. Dermoscopically, it's a two-tone lesion, but not really all that scary. So pathologically, this is a melanoma in situ. It wasn't right for her. It didn't match her pattern. That's unusual from your viewpoint. But unusual doesn't have to basically be what you're seeing. It can also be what the patient is pointing out. All these lesions may look a little unusual to you, but really only one of them is a melanoma. One of these lesions was a lesion that the patient pointed out, and it's this one. Going to photos, it was a growing, changing lesion, and actually was an early in situ melanoma. So unusual can also be the lesion the patient's paying attention to. They've got 500 moles. They're worried about this one little spot. Why is that? You need to think about that. That's unusual. There's something that mole is telling the patient. Well, histamine release, something. The patient has noticed something. If they're pointing out a spot, it's important to kind of pay attention to that and include that kind of in that unusual diagnosis. I do like growth, and we did discuss how you can use dermoscopy to follow growth. Certainly in high-risk patients, it's nice to have photos. Basically, if you look at number of lesions, you can certainly have lesions that have not changed. That would not be a lesion that you'd be worried about. You can have lesions that are non-uniform, but also not changing. And that lack of change makes you feel more comfortable that that's a benign lesion. You can have uniform lesions that are changing, but all acquired nevi are new at some point. Just because it's new doesn't mean it's bad. In fact, on any given patient with this kind of moles, roughly 3 to 5% of those moles are changing on an annual basis. So if it's uniform, it looks like the other moles on the patient, even if it's new, it's probably fine. These would be other examples of growing nevi that were in fact just nevi, very uniform type of lesions with relatively benign dermoscopic features. So again, what we're looking for is what's unusual for that patient, something that just doesn't match their others, a spot that maybe they're focused on, and that's growing. And those scenarios really can be pay attention, because that's probably where the real early melanomas are. As they become non-uniform, they're becoming more and more advanced. So I want to kind of go over uniform.